Hello, everyone. I thank you very much to Leah for introducing me this morning, and thank you very much to all of you for joining us. The part of the presentation that I'm going to cover is the section about who does what in the public sphere in health. And by that, I mean, what are the roles of different stakeholders in the health sphere? So this is a complex drawing, I think, to show that it is a very complex pathway from drug development, which is at the top of our slide, down through to patient access, which is at the bottom of our slide. And most of what we see in the middle, although not all, but most, is different federal and provincial lawmakers, policymakers, and policy implementers in the health sphere. So let's start with the role of our federal government in healthcare delivery and in healthcare policymaking. The federal government has the role by law through the Canada Health Act of ensuring universal access to doctors and hospitals in Canada. So that means that no one should have to pay to see a doctor or to get into a hospital. That's promised to everybody wherever they live in Canada. And the federal government also, through Health Canada and through the Food and Drugs Act and Vanessa's law, approves clinical trials, approves treatments for sale in Canada, approves medical devices for sale in Canada, approves over-the-counter drugs, and also does post-market surveillance of drugs that have been approved, drugs and devices that have been approved, including removing them from sale through Vanessa's law if they're found to require that. In addition, the federal government regulates the price of drugs entering Canada in order to ensure that the prices are not excessive. And this is done through the Patent Act and the Patent Act regulations, as well as the Patented Medicine Prices Review Guidelines. And the overseer of these activities is the Patented Medicine Prices Review Board. In addition, the federal government manages public health policy, including pandemic planning, particularly through the Public Health Agency of Canada, and it also manages insurance company activities as they are interprovincial works. In addition, on the implementation side, the federal government does provide direct drug coverage for federal employees and retirees, for the military, for the RCMP, for Indigenous peoples on reserve, for people in federal penitentiaries, and for refugees. And that's done through the Constitution Act. As well, they implement specific health strategies, such as the HIV strategy, the mental health strategy, and the cancer strategies at the federal level. In addition, they develop medical best practice guidelines in selected areas. In terms of monitoring and evaluation, the federal government monitors treatments post-approval for safety and efficacy. And these days we talk a lot about real-world evidence and the collection of that, and that's done post-marketing. They also monitor excessive pricing over time through the Patent Act and the PMPRB guidelines. They provide transfer payments for health to the provinces, sometimes with conditions for the use of those funds through the Canada Health Transfers, which are provided in the federal budget, and they collect data. This is generally done through CIHI, and more recently, also through the Public Health Agency, there's a data management strategy that's being undertaken to try to coordinate data across the country. And for infectious diseases, the Public Health Agency has responsibility primarily for that work. Now, what do we kind of see coming up on the federal horizon in terms of changes in 2023 and beyond? We do know that there is a Canadian Drug Agency which has been recently created. Its role is still fairly undefined to date. It has taken on the responsibility of creating lists of drugs in particular disease areas, but what will be done with those lists and how they might be part of a larger pharmacare policy, as it's been called, is still very unclear, and that should start to become clearer as we go forward. There's definitely going to be a lot of conversation around the Canada Health transfers to the provinces. The federal government has been demanding links to measurable outcomes by the provinces in order to increase the Canada Health transfers. The provinces have primarily or basically balked at this request, saying that they deliver the services, they know what services need to be delivered, and they do not have a responsibility to define for the federal government exactly how they're spending that money. And there's quite a standoff right now, as you probably well know, between the provinces and the federal government on this point. Certainly the amount that the federal government has been paying in health transfers has gone down over time, and costs have gone up over time for the provinces. So this is certainly a big sticking point. I think we should anticipate that the rare disease strategy, which has been under discussion for quite some time, will probably be better fleshed out over the next year or so. And that would certainly be very important for many people with rare diseases who have found themselves unable to access treatments because they're so expensive. There's been a lot of issues around seniors' homes, really pre-pandemic, but now obviously post-pandemic. And we may start to see more pan-Canadian standards of practice and care there. Integration of the use of virtual care in providing healthcare services to people will probably continue to be more refined and defined as we move forward. As you know, they were brought in on an emergency basis during the pandemic and were quite widely used during the pandemic. And now the question is, in the long run, for the long term, where are they best used, most appropriately used, and where is face-to-face meetings with doctors still very important? I think we're probably going to continue to see changes to the CADA health technology management approach. CADA is the health technology assessment body that, except for Quebec, determines value for provincial reimbursers and provides recommendations to them about value in terms of paying for medications through public reimbursement plans. And they've moved from calling themselves a health technology assessment program to a health technology management program. So we'll see what that means. And they've certainly started to move into the area of real world evidence, and we'll see that probably becoming more refined as well in terms of their approach there. Health Canada continues to move into what they call agile review regulations. That is speeding up the review of drugs that are most badly needed by people in Canada. We're probably going to see, as I mentioned earlier, the Pan-Canadian Data Management Strategy, which is presently being facilitated through the Public Health Agency of Canada, increase its reach out to the provinces with an attempt to align data across the country that's being collected and shared. And we're probably going to see much a greater use of real world evidence and real world data in decision making about treatments. I think there's definitely going to be an increased use of pay for performance agreements, risk sharing agreements, and other models of payment between the provinces and industry, and that will probably be done through the Pan-Canadian Pharmaceutical Alliance. Unfortunately, the most recent COVID pandemic is continuing, and it has also created what some of us have called echo pandemics, particularly in cancer, in mental health, and in older adults. And these certainly have not abated. We have not been able to catch up on the delays across the continuum for these patients, from screening and diagnosis all the way through treatment and palliative care. And I think a lot more work is going to need to be done in these areas. So there are, in addition to the areas where the federal government has discrete jurisdiction, there are areas where the federal government and the provinces share jurisdiction. One place, as I've mentioned, in the area of law and policy, is the joint reimbursement recommendation bodies for public reimbursement. And those include, as I've mentioned, the Canadian Agency for Drugs and Technologies in Health, which is the health technology assessment body for public reimbursers except in Quebec, and INES is the body that provides that in Quebec. In addition, there are other joint price and other conditions negotiation bodies for public plans, including the Pan-Canadian Pharmaceutical Alliance, which jointly negotiates prices and other conditions for provinces to accept drugs on their listing or formulary agreements. In addition to law and policy, the provinces and the federal government work together through agencies like the Canadian Association of Provincial Cancer Agencies, meetings of the federal, provincial, and territorial health leaders, where they set, evaluate, and recalibrate policies. And there's the Council of the Federation, which is the body that created the Pan-Canadian Pharmaceutical Alliance, and which is actually a meeting of all of the premiers. And then solely in the jurisdiction of the provinces in health, in law and policy, we have what has been called our patchwork quilt for the actual provision of healthcare services. So each province actually develops its own health systems, its own health budgets, its own health drug reimbursement plans for eligible provincial residents. So while CADA provides recommendations to all of the provinces about value for reimbursement, each province will take a look at those recommendations, and even after there has been negotiations through the Pan-Canadian Pharmaceutical Alliance, they will make the decision individually whether and when they wish to put drugs on their individual provincial formulary. They also develop specific programs for specific populations, such as seniors and disease groups, including cancer and mental health. And they also develop Indigenous health programs for people off reserve. In the implementation area, each province manages all aspects of its health delivery systems, including hospitals, private clinics, pharmacies, doctors, public drug brands, primary care, long-term care, home care, and mental health. It manages its cancer agencies, It manages data collection for the province. It manages a huge health bureaucracy. It manages clinical trial implementation, as well as implementation of public health measures, with the municipalities also having a public health role. And in terms of monitoring and evaluation, part 3, they budget control through each ministry and the Treasury Board. They have quality control programs for the province, and they have health advisory boards and committees. Private insurance, as I've mentioned, the federal government actually manages the law of private insurance. In terms of implementation, the companies will contract with employers, unions, individuals, and other groups to provide all kinds of insurance, including drug insurance, dental insurance, medical and disability insurance, life insurance, and pensions. We've noticed recently that although the intent of private insurance was always to be able to pay for more than what was available to people through the public reimbursement plans, there seems to be much more of an alignment between what the private plans are providing and what the public plans are providing. So there's some real questions, I think, by a lot of people as to where the value add really is in private insurance. They work through benefits consultants and human resources professionals to provide them advice about trends, costs, and prices for their services. And they monitor and evaluate their own members through CLIA, and the federal government monitors the work of the agencies, private insurance agencies themselves. So, as you saw from the very first slide, which is very complex, this is another way of looking at that same complex list. So we start, of course, with the development of the drugs. And once a company feels that it has a drug that has passed through the phases of trial development, usually at least 3 phases, although some drugs are approved after 2 phases of trial development, they move to Health Canada and they make an application to Health Canada to have the drug sold in Canada. And so that generally is done on the basis of looking at the safety, efficacy, and manufacturing quality of the drugs. And we will either get a notice of condition or a notice of a notice of compliance or a notice of compliance with conditions. And those are generally for drugs that are approved early after 24 weeks of data, rather than the 48-week notice of compliance. Then the drug moves to the Patented Medicine Prices Review Board, and there's much complexity in the work that they do in terms of determining what's in excess of price. And in fact, there's a great deal of shift at the very moment in terms of the guidelines that the Patented Medicine Prices Review Board is proposing to use. We don't have time to go into all of that in this webinar, but it is very much a work in flux. And but the purpose is to make sure that the price that's coming into Canada for our drugs that's being proposed by the manufacturer is not excessive compared primarily to a basket of 11 countries, and maybe also some other conditions within Canada in terms of drug pricing. At the same time as the Patent Medicine Prices Review Board is doing its work, the file will move to Category for the value proposition for the public reimbursement funds. And almost all drugs go through one of those 2 programs, although a few may just go directly to local or regional reviews, such as generic drugs and older medications, and then to the Pan-Canadian Pharmaceutical Alliance for the negotiation of the price and other conditions that they will impose and negotiate with the industry in order to make a recommendation to the provinces. And then finally, we move to we move to either the public reimbursers individually, that is the provinces, and they may or may not accept the recommendations that CAT and INES make about putting a drug on the formulary. They may also move on to private drug benefit plans. And in fact, that can often happen even before a drug goes through CAT or INES because the private insurers make their own decisions. And of course, people can then either get the drugs if they're accepted through public reimbursement. People may get them through formulary listing. If not, and there may be conditions to that as well. If not, they may go on to the private plans. And if you have a private plan, you may very well get the drug that way. And as I've mentioned, we now have it's actually the Canadian Drug Agency, and a lot of people call it Canada Drug Agency, but I think it's actually the Canadian Drug Agency. And as I've said, their role is still in flux, and what it will be determined over time. So, so that's kind of an overview of the complex system that we have for drug access in this country, partly federal, partly provincial, and partly jointly held by them, as well as some private insurance. I'm going to turn it over to Leah to talk about who does what in the public sphere in terms of social determinants of health.
Thank you so much, Louise. I'm going to briefly touch on the determinants of health, health equity, inequity, the relationship between these things, and then touch on who does what in the public sphere of different jurisdictions, federal, provincial, territorial, and municipal, when it comes to a couple of different determinants of health, because there are numerous. I'm just going to pick on three. And talk about some of the different roles of different levels of government therein, and then explore a little bit about the implications of the fragmentation in responsibility amongst the jurisdictions when it comes to healthcare and the determinants of health, and how that represents its own form of health inequity in Canada. So this definition and this list of determinants of health comes to us from Health Canada. And really, the determinants of health are the broad range of personal, social, economic, and environmental factors that determine individual and population level health. And the main determinants of health that have been identified by Health Canada include income, social status, employment and working conditions, education, literacy, childhood experiences, specifically adverse childhood experiences, physical environments, social supports and coping skills, healthy behaviors, access to health services, biology and genetic endowment, gender, culture, and the experience of racialization and racism. So I just wanted to spend a bit of time clarifying what these different terms are as well: health equity, health inequity, health inequality, and discuss briefly the relationship between the determinants of health and health inequalities. So differences in health status between individuals and groups. So these are health inequalities. So they can be differences between individuals, they can be differences between groups of people, subpopulations, you could say, or segments of the population. Health inequity are health inequalities that are unfair and modifiable. So they can be changed and they're not just. Health equity is the absence of unfair systems and policies that cause health inequalities. To frame it more positively, health equity are fair systems and policies that promote health for everybody. That's I think the positive way of framing health equity, which is important because health equity is meant as a positive goal. So ultimately, interventions that are in the realm of health equity are seeking to reduce inequalities, and are seeking to increase the access of to opportunities and conditions that are conducive to health for everybody. So, but you're looking at the specific needs of different individuals and or groups who are experiencing health inequalities. You're trying to achieve the same health outcomes for everybody, for all. You're doing so by understanding those inequalities, who are differentially negatively affected or having negative outcomes, and finding interventions, finding root causes to be able to make sure that everybody is able to achieve the best possible health and well-being. So determinants of health influence health inequalities. When we're able to do something about these health differences, we're dealing with health inequities, and when they're unjust, and that really is the majority of them. So determinants of health and health inequity and health equity, they're not the same thing. They're not interchangeable terms, but they're very closely linked to each other. So things like having a lower income or less education, less literacy, more adverse childhood events, growing up in a poor environment where you have difficulty eating well, sleeping well, accessing healthcare services or other types of social services, experiencing aggression because of racialization. These are the types of factors, and they compound upon each other when we have intersectionality at play. These are the types of factors that, unsurprisingly, are related to differences in health status. And these differences are largely due to unfair and modifiable or changeable conditions. They're things that we can do something about. So this picture, or variations on this picture, are quite popular right now. Sometimes you'll see them with apples as well. But it's to help us understand a little bit the differences between, we get a bit confused about, okay, we need to be equal, we need to be the same, but what about equity? We don't want to be differentiating, and we want to treat everyone equally. Picture number one is same treatment. One could say equal treatment. Everyone is receiving one box. It's equal treatment of all people. But you have one person who is tall, one who is short, and one who is in a wheelchair. So that one box is not benefiting the person in the wheelchair whatsoever, although they're all being given equal or the same treatment. Equitable treatment is the middle picture, and it's providing different interventions for different people's needs. So the tall person doesn't need a box, the short person needs two boxes, and the person in a wheelchair needs a ramp. And now they can all see the game, and they can all see over the barrier to enjoy the game. And so this is equitable treatment. This is providing different solutions, different interventions, different approaches, depending on the differing needs of individuals in this case, but also of communities, of of groups of people. For example, probably everyone in a wheelchair was going to need a ramp. The third example is what some would call justice. I think this group is calling it equality, but that can also be confusing for people. So basically, the systemic barrier has fundamentally been removed. That wall that was in the way, preventing everybody from being able to see and enjoy the game, has been removed. So now you have achieved what some would call justice. In this case, they call it equality. But I think equality can be a little bit confusing, as I said, because people get confused with picture number one and they think, well, no, we need to treat everybody equally, right? No, what you want to achieve is picture number three, equal outcomes for everybody. You might need to have different interventions to be able to achieve it, such as picture number two, or perhaps there's a larger systemic barrier, whether it be at the policy level, institutional level, a combination therein, that if it can be removed, when it can be removed, actually fundamentally creates a just and level playing field for everybody. And then just a brief note on Indigenous population and individual health and processes, but to acknowledge the distinct worldviews and epistemologies, ways of knowing and being that are um, that are distinct across hundreds of nations across Canada, or Turtle Island, and acknowledging that discrimination, stigma, and genocidal policies and practices have led to the intergenerational trauma and poor determinants of health, health status, and outcomes for First Nations, Inuit, and Métis um, brothers and sisters in Canada. And so when we're working um, with our colleagues from First Nations, Inuit, and Métis uh, groups, associations, communities, healthcare providers, it's vital that their leadership, uh, their governance and leadership be at the forefront, so that those worldviews, those epistemologies, those ways of knowing and doing are really really driving the work, and the people with the lived experience with those distinct worldviews and epistemologies that are distinct are really taking the lead of the project from the outset and leading that decision making throughout. And things like when it comes to data consideration, things like the OCAP principles, ownership, control, access, and possession, are really being meaningfully considered and embedded in the work. So really self-governing, and partnership and self-governance are really key here in order to be able to shift and make a difference as it relates to the determinants of health and system level changes and achieving health and well-being for First Nations, Inuit, and Métis. It really needs to be with First Nations, Inuit, and Métis. So a little bit on 3 different determinants of health and different levels of government's roles in those determinants of health. So Louise has covered the allocation of responsibilities related to access to health services and health products and devices really thoroughly in a great amount of detail already. So these are 3 examples of determinants of health: income, education, and physical environments. And we've brought in the municipal level here because they actually, depending on the determinant of health, they can have quite a bit of responsibility associated with different determinants of health. Income is an example where there is perhaps some of the most blurring between and overlap between different levels of government. Provinces and territories, however, have a very important responsibility of legislating employment standards and providing social assistance. So they carry a great deal of responsibility when it comes to employment, as well as to social services and benefits. Of course, the federal government, though, has enormous roles. And when you look at something like CPP or pensions, I mean, this is a form of, you paid into it, but guaranteed income once you reach a certain age. So it's a very important role at the federal level. And many larger municipalities have some degree of role. They may have family and community support services and different types of income supports. Education, the provinces and territories carry most of the weight related to education as well. Obviously, but the federal government is absolutely vital for financial support, but also it must be, just like in healthcare, it's important to recognize that the federal government has direct responsibility for education delivery for Indigenous peoples on reserve, for military and Coast Guard personnel, and for federal inmates. While at the municipal level, we have our municipally elected school boards that really undertake the local implementation of elementary and secondary education, although that's funded at the provincial level. And physical environments is an interesting example because it's an area where municipalities carry a lot of the responsibilities. Um, Physical environments are many of those assets are local in nature. So whether it's municipal land use and taxation, local parks, public lighting, public transit, recreation and community infrastructure, local roads, water and sewage, waste management. These are all physical environment infrastructure responsibilities that reside at the municipal level. The provincial and federal governments play key roles within their own jurisdictions, obviously, but especially when you're looking at major infrastructure investments, subsidized community housing that might be provided at the municipal level, for example, which obviously we don't have enough of across the country. Then you really are looking at the need for collaboration and shared investment across all three levels of governments. Public infrastructure is, I would say, a common good. It's an expensive one. It requires often joint planning, excuse me, and large investments for long-term expenditures that are going to have hopefully a long-term lifespan and require ongoing maintenance. So, there is often you will see there are, joint investments for large physical environment and infrastructure investments, because to expect the municipal level to be able to afford it all through a limited tax base is asking too much. So just want to spend a couple of minutes exploring and talking about the lack of jurisdictional collaboration on a systemic basis. So as Louise has pointed out, when it comes to healthcare systems, we have a very complex interplay going on at the public level between different national bodies, federally sponsored bodies, or just, national level organizations, and then provinces and territories. And obviously, when it comes to the determinants of health, you have that much more overlay of different responsibilities by different levels of government, including the municipal level. And so I want to share a story with you, and a very real dynamic that plays out every day as a kind of illustration for how this lack of the fact that these different levels and these different jurisdictional responsibilities, without there being ongoing learning and collaboration between them and active collaboration between them, to systematically align with each other and be as efficient with each other as possible and make good decisions that make sense across for the population, for individuals. How without having that, you have really negative impacts on people's lives and health outcomes to the point of mortality, of course. And so is that lack of collaboration and creating systemic ways of having that kind of collaboration between jurisdictions that have common responsibilities in different areas of health care or determinants of health, is that not its own systemic inequity that's driving health inequalities? And the example I'd like to give relates to Indigenous health responsibilities and something called Jordan's Principle. And it's an example of the push and pull between the federal government and the provinces and territories based on whether a person lives on or off reserves. So if you are deemed as being from a First Nation on reserve, then the federal government has responsibility for most things, including healthcare. If you are deemed as being off reserve, living in a city or whatever the case may be, then the provinces and the territories tend to pick up the difference. So Jordan's Principle was established by First Nations in response to the death of a 5-year-old named Jordan River Anderson, and he was a child from Norway House Cree Nation. He had a condition called Carey-Feynman-Zeter syndrome. It's a rare muscular disorder that required years of medical treatment in a Winnipeg hospital. And after spending the first 2 years of his life in a hospital, doctors were able to clear Jordan to live in a family home near the hospital in Winnipeg. However, the federal and provincial governments could not resolve who was financially responsible for the necessary home care for Jordan. So, for over 2 years, the government of Canada and the government of Manitoba argued while Jordan remained in the hospital. And in 2005, at the age of 5 years old, Jordan died in the hospital. He never had the opportunity to live in a family home. So, Jordan's principle is a child first and needs based principle that's used in public policy administration in Canada to ensure that First Nations children living on and off reserve have equitable access to all government funded public services. It holds that First Nations children should not be denied access to public services while governments debate who should pay. So, according to the First Nations Child and Family Caring Society of Canada, the organization that hosts the Jordan's Principle campaign, Jordan's Principle should ensure that First Nations children can access all public services when they need them. Services need to be culturally based, take into full account the historical disadvantage linked to colonization that many First Nations children live with. The government of first contact should pay for the service and resolve jurisdictional and or any payment disputes later. So basically, first one, whether it's provincial or federal, that comes into contact with the need of that child should just do the right thing and then sort out who's responsible for it afterwards. If it's going to be a 2 year, battle between the two different levels, that's fine, figure it out, but don't leave the person in limbo. Wouldn't it be nice, though, if there was actually proactive collaboration and understanding between these different levels, especially when there's regular contact between them, because these sorts of examples, like Jordan, are not one offs. They happen every single day. There are hundreds, if not thousands, of communities across Canada and individuals, patients that are affected by interjurisdictional barriers and boundaries. And you do not need to be Indigenous to experience them. You can be a patient in Alberta who needs to receive the best care in another province and unable to do so because of payment debates. So Canada Health transfers and the need for data collaboration and this whole conversation that's happening right now around that is it's another example of sort of the symptoms of our lack of collaboration. There's a whole thing of, okay, well, what does success look like in healthcare? What are the metrics for success so that we can increase the Canada Health transfers? Or, can we have a health data strategy so that there's interoperable, person-centered health data available across the country, so accessible across the country, so that we're able to, obviously still secure and not easily hackable, but so that we can have better understanding at the level of care of our own individual care, a better understanding at the level of the institutions and services providing that care and the systems funding it and planning it. Can they not learn more from each other from all of this? And researchers looking for innovations and new breakthroughs and understandings in disease areas and treatments and service delivery and all of that good stuff and outcomes. So really having these tables and ability to be able to collaborate, some kind of table and ability to collaborate across the different jurisdictions on these common issues, uh, and needs, where there needs to be some degree of vision and commonality in the foundational principles, acknowledging that there are different jurisdictional responsibilities, but we are all Canadian citizens, or most of us. Some of us are still waiting for citizenship, or are newcomers or refugees, but we are either Canadian citizens or people living in Canada, aiming for some form of residency and citizenship. And we need to be able to live in all sorts of different parts of the country and expect those principles of the Canada Health Act to be what we experience. And so that's not always the case because of that's not the case because of all the jurisdictional differences, which we recognize there's different levels of responsibility there. But there need to be ways for there to be systemic collaboration on those key issues, such as can we have health data available across the country so that when things like pandemics hit, we're able to very rapidly understand what's going on. But even when we're not dealing with the pandemic, we can make better decisions and have better understanding about how to achieve the best health outcomes for ourselves individually and for our population as a whole and for different segments of our population who face health inequalities. Fundamentally, we need to work better together. And when we don't, those jurisdictional barriers and divisions can form their own form, that they create their own form of inequity and fuel uh, um, inequities in healthcare and health outcomes. So, where does the summit fit? The summit was started 7 years ago as an education and awareness event and focusing in on government health systems and policy, uh, aiming to really address the needs of patients and their representatives when it comes to understanding the complexity of government health systems and policy. Evaluations recommended that the event become annual and that include patient action planning. So the second summit introduced the concept of value-based healthcare, and our third webinar really dove into what value-based healthcare is as a reminder for everyone. So do check that out if you want a refresher. And talked about the key principles that underpin value-based healthcare. And this concept was endorsed by patient groups in attendance. So an action plan was developed, including forming patient working groups and looking at value-based healthcare more closely as it relates to different healthcare stakeholders and what it means in Canada. So the third summit drilled down more on value-based healthcare principles that needed the most attention in Canada, and that we were really looking at data, patient-reported outcome measures, and examples of integrated models of care. So the working groups have been sustained, and they have one of them developed a declaration of personal health data rights in Canada, have analyzed proms and looked at examples of implementation. There's been an analysis of integrated models of care definitions and strategies, tactics, and a draft case study has been created. And each year, the summit has expanded its discussions of value-based healthcare, resilient healthcare systems, and moving more towards beyond resiliency and concepts of anti-fragility. Again, check out webinar number 3 for more on this. And things like a data management strategy and how that's such a core enabler of value-based healthcare and more than resilient healthcare systems. The summit now includes educational and advocacy discussions in health and related issues from Indigenous worldviews led by Indigenous leadership. Also really trying to understand better the determinants of health and the social determinants of health and how they relate to health. And for the last 2 years, our virtual summits have examined the inequitable health outcomes and access to healthcare experienced by key populations and exacerbated by COVID-19. And we're exploring now the echo pandemics and their ways forward. So the long tails and the ongoing impacts caused by COVID-19. What are those? How do they affect different key populations? And what do we need to do to move forward above and beyond them? Thank you so much.